Staff meeting of the Hamilton County Board of County Commissioners. It's 513 day. It's May 13th, 2025. We've got a couple of presentations here today. The first one is about situational awareness and learning. Presentation. Greg Kesterman is here, Public Health Commissioner. Tiffany Mattingly is here with the Health Collaborative. And David Hartley, I believe, has joined us virtually. He's from Children's Hospital to walk us through this presentation. And my understanding is that this is a recognition of what we learned during COVID when we were all a little out of our depth to begin with, but figured it out and learned to work together in a collaborative way to set up systems that were good for responding to the needs of the community. It was ARPA related, it was ARPA funded, and so we are looking then to take these tools and this collaborative effort and move it into continued work throughout the county. It doesn't have to be ARPA related, but rather relationship related. So, Tiffany, I guess you are going to present.
Actually, David's going to kick us off. He did say it's a little hard to keep. Oh, no, never mind. He gave me a thumbs up. We're doing a lot of virtual stuff here. So I'm going to keep him on my phone here just in case, but he is going to kick us off. Oh, and there he is. Great.
Yes. Can you hear me? All right. I will go ahead and share my screen and begin. All right. Well, thank you very much for the opportunity to come and present the work that you very graciously funded now about 2 years ago. What I'd like to do today in this briefing is summarize the project, and in particular describe the users and the stakeholders that this was designed for and with, talk about how we designed it and the design objectives, share a little bit about the resources that we use in terms of data, and then finally demonstrate the product. And as Commissioner Driehaus just described, share a bit about our thinking on sustainability moving forward. So again, thank you very much for funding this through American Recovery Plan Act, or ARPA funding. SALT is a partnership between Cincinnati Children's Hospital and the Health Collaborative, and this grew out of the work that we did during COVID-19, where we developed a data approach, a data and analytics approach to understand what was going on in our region in order to better help public health and hospital operations for that event. That work evolved throughout the pandemic and has continued to this day, including partially and importantly under the guise of the SALT project. So the objective was to build and maintain that capability that allows for many issues, many things to be done, including sharing data, coordinating and collaborating across sectors, analyzing the data to inform stakeholders of the things they need to know about, i.e. situational awareness, to protect the health and well-being of citizens in and around our community. This is embodied in the Amazon cloud, and it is available as a web page, as we will see in a few slides. It supports communications with stakeholders at varying levels of security and access, ranging from publicly available data, which we'll show today, to data that are protected or need to be protected. The team at Cincinnati Children's includes myself, Andy Beck, and Cole Brokamp, and at the Health Collaborative, Tiffany Mattingly. Although these are four names, these are placeholders for a lot of other people that work to execute this project. It started in March of 2023, and it will end June of this year. And now I'd like to ask Tiffany Mattingly to share a bit about how we designed this and the stakeholders for whom it was designed.
Sure. Thanks, David. Can everybody hear me okay? Okay, great. Thank you. So we have our core users that we designed SALT under kind of the core users, which is Hamilton County Public Health, our Regional Hospital Steering Committee, which is comprised of chief operating, medical, and nursing officers within Southwest Ohio, and our Regional Multi-Agency Coalition, which is comprised of representatives from skilled nursing facilities, emergency management agencies, public health, and the hospitals, as well as our disaster preparedness coalition. And then we have additional users and stakeholders of SALT, which are also other public health departments across the region, other COVID-19 advocates, such as our medical professional organizations here locally, community health partners around our region, and emergency management agencies. So kind of think of that larger, broader group of stakeholders that were at the table during COVID, but weren't specific to public health or our hospitals. So on the next slide, David, we're going to talk about our design approach. And so what we really wanted to do was pull together stakeholders and learn from them how they used the reports during COVID-19. So the Health Collaborative and Children's and partnership with public health and others, we were collecting data rapidly and trying to get it out to users as quickly as possible to help them have the situational awareness they needed to keep people safe, but also to allow them the opportunity to make those very quick, rapid, informed decisions. And so our first round was really pulling together our public health departments and emergency management agencies to really listen from them. So we conducted these listening sessions or focus groups with users of the previous reports to understand from their perspective the most useful data that was provided during COVID-19 for situational awareness and action, and then to help us identify what was missing and what was clunky about the previous report. So we held a listening session with public health, and we held a listening session with emergency management participants. We put the previous reports in front of them, asked them to think back to those days where they were using these reports and understand what went well and what didn't go well. And so basically we wanted to know, what their suggestions were for either changes, enhancements, or what could be deleted from the report to kind of decrease the noise of the data and information coming in. And then we held a second round. So we went back to the drawing board, we applied what we learned, and David started working on some prototypes, and David and his team. And so we developed a second round where we shared those prototypes with the same participants from public health and emergency management agencies to really gather feedback on the utility of the prototype, and then taking that back for improvement. So looking at how the data was laid out, what the visualizations look like, the ease and use of the platform itself, the user experience, and then we took that back for the next round. So on the next slide, David, and there's a lot on this slide, but our design objectives were that we learned from the listening sessions that we learned from our listening sessions that stakeholders and users emphasize that SALT should address limitations in data and situational awareness experienced during COVID-19, and that solutions should be efficient, effective, timely, and scalable. So you'll see the first group here, and reminder, we really asked them to help us identify what should be changed, enhanced, or deleted. That the users wanted to see integrated data from multiple sources, so being able to rapidly pull data from multiple sources into one location. They would like tailored dashboards for specific audiences, whether you're talking to the county, whether you're talking to public health officials or to hospitals or to the community at large, and that the legal frameworks need to be in place well before a pandemic threatens the health and lives of the community. We learned this during COVID. Legal frameworks take time, and we lost a lot of time during COVID trying to get those legal frameworks in place where we could share data out publicly and with those who were the decision makers at the table. So SALT has allowed us to work through and clean up those legal frameworks with the hospitals and with public health, and really set us up for success moving forward. And then the second focus group affirmed the effectiveness in enhancing decision-making and strategic planning by using the SALT platform. So, we learned that from their perspective, the existence in and of itself of the platform could facilitate rapid situational awareness and decision-making in the event of an emerging or current health threat. So they suggested availability of multiple measures and data elements in one place is very valuable for speed and efficiency. They provided us suggestions that a need for visualizations and further narrative around explanations of what the data means and how they can then take that data to make decisions or to inform others would be helpful. So we looked at how do we provide measure definitions or information about the data that we're putting in front of people to help them make those decisions and have better situational awareness. And then we learned that additional measures and disaggregation could create additional usability. And so from there, I'm going to turn it back over to David. He'll talk with the group about our data sources.
Currently, we ingest and use data from different sources that span the state to federal level, and actually even the local level. So, for example, we use information and data from the Centers for Disease Control and Prevention, and those are things like the % of emergency department visits diagnosed as COVID-19 or other respiratory infections, which are also of interest for preparedness reasons. We also monitor the amount of virus circulating in wastewater. From the U.S. Census Department, we utilize population estimates for Hamilton County and surrounding areas. From the Ohio Department of Public Health, we utilize COVID-19 cases per 100,000, so the prevalence of COVID-19. We also, and the incidence as well, so new cases. We also are able to split those data down into new cases per age group. And we also track the number of COVID-19 deaths in the region. Local data include data from the EPIC electronic health record, which is the contributed de-identified data from local hospitals who use the EPIC software for their electronic health record. These are data that, as I said, are de-identified and not traceable back to individuals, but nonetheless give us very important data about things that are happening here at the county level in Southwest Ohio. And right now we're looking at COVID-19 as well as influenza and RSV presentations to the emergency department. Given some of the recent news, you may have heard that some of these data sources, particularly from the CDC and the Census Department, have had disruptions in the last couple of months. We have been able to compensate for those, and those data are currently back up and available. But it underscores an important point that it's important to have access to data that we aren't necessarily dependent upon others to provide. And so with that, I'd like to ask Tiffany to describe some of the additional data that we are including in SALT.
Thanks, David. So as David mentioned, there's been disruptions in federal and state data sources over the last couple of months that has disrupted our ability to provide timely situational awareness related to COVID and influenza. And so some of our goals with SALT, and specifically what we heard from our stakeholders as well, is that a solution needs to be sustainable and long-term, and that we can be autonomous down here in Southwest Ohio to monitor time-sensitive data, that we are not codependent on state or federal data solutions, that we can create those solutions here locally that are personalized to the data we need when we need it to make informed decisions here at our region or county level. And that enables the rapid development of new measures on emerging trends. So if we can keep things here locally and have that local control, that we have the ability to respond in a timely manner. And we saw that during COVID with our health information exchange when we were the HIE in Southwest Ohio. We had COVID positivity rates far before the state knew what was going on. And we want to maintain that independence down here. We have to do it a little differently. And so that's what we're looking at, being able to use the SALT platform for that, but then to also, we had to go back to the drawing table, and SALT has provided us the opportunity to do that, to test submission of data by the hospitals to the Health Collaborative. So not a health information exchange specifically, but more about capacity and capacity and utilization of the hospitals during times of heightened either flu or COVID-19 or anything else that might come our way, whether it's measles or something else that's not even yet on our radar. So that we are currently testing that, how the hospitals can submit the data to us. I talked about those legal agreements. It took a very long time to get in place. It took us almost a year to get those legal agreements in place with the hospitals. That is now in place, and we can now move forward with those submissions, aligning on data measures and how the hospitals are going to submit that data to us, ingest it into our warehouse, do the analytics, get it over to Children's, and get it out to the SALT platform that David will show you here in a couple of minutes. And then we're in parallel testing a second exercise with CliniSync. So figuring out how we're partnering with the sole information exchange across the state of Ohio to collect the same type of data from CliniSync. And learning what measures align, what can CliniSync capture related to what the hospitals can submit. The hospitals, as expected, can submit more data than what CliniSync can capture, so understanding what those gaps are and then doing the quality assurance on that data collection. And then, as David mentioned, we are looking at Epic Cosmos as well.
Right, thank you. So this is the URL that one can click on to bring up SALT. I will transition now to a very brief definition because I'm mindful of time. So when you click that link, you will be, your web browser will come up and you will be led to this URL, and this will be the first thing that you see. So this shows for the United States, for example, data from the CDC on the percentage of emergency department visits for COVID-19, influenza, and RSV. And this is important because this gives you an idea of what's going on at the national level, and that has implications for what's going on more locally. And for example, you can see that in Ohio, these are the same data for the state. You can see that we had a very high, in fact, higher than the national level maximum for influenza this year. The emergency departments were quite busy with flu cases throughout the year. But then we can also drill down further and we can look at the data from the Ohio Department of Health, for example, for our region. So we refer to this as, the state of Ohio refers to Region 6 as these 8 counties, of which Hamilton County is a part of. And we can see, for example, the COVID-19 incidence, so the number of new cases per week per 100,000 population, and how that's changed over time. And you can understand where one county is relative to other counties. But we can also drill down and we can look at those data as structured by age. So we can, for example, look at trends in persons that are generally school age relative to different decades of life for adults and for elderly populations as well. We can also gain a sense of what's going on by looking at the virus concentration in sewage and wastewater. Here for Region 6 are 6 of the wastewater districts that monitor for virus. And we can see, again, how these change over time. And we can see right now that we're quite low for virus detection, which means that COVID-19 virus is circulating very weakly in the population at the moment. We can look at how cases are occurring at the state level as well for COVID-19. We can monitor the death rate in Ohio. And then here are the more local data for an ED, for emergency departments admissions per week for influenza. These are from the Epic Cosmos data set that's for COVID-19. Here it is for influenza and for RSV. And then just to make the point, this has been developed so that we can look at any region and any county in Ohio. So for example, what's going on to our immediate north is oftentimes important because it can portend the conditions that we're likely to see here. We can look at the conditions to our immediate east, and so on and so forth. And we can look at all of those data because they're provided by the Ohio Department of Health. And so what I would like to do now is go back and talk about how we plan to sustain this capability moving forward. So our goal is to have SALT be a preparedness tool, have it being a living tool that's always at the forefront of technology and best practices, which means we have to continually drill on this, practice our situational awareness approach for COVID-19 and flu, yes, but also for other complex unsolved conditions that that our community is facing. And so those could be things such as health inequalities, such as asthma, such as food security, mental health, etc. And we plan to make SALT available on a for-fee basis to support SALT moving forward, but more importantly, to make this capability available in those areas where it may add value. And our approach is to make this available to anyone who can utilize it. That includes hospitals, local health departments, researchers, government, community health advocates, and others. What I want to do is to show what that could look like. What I'm about to show are notional, fictitious at the moment. They are what we refer to as wireframes of what we could design and host on SALT for some non-COVID areas, just for purposes of illustration. So for example, asthma is an important community health issue in many places in the United States, including Hamilton County. A SALT capability for asthma could look something like this, where you have a map of different neighborhoods in Hamilton County. You could imagine clicking on any particular area of interest and bringing up data that's relevant to asthma control or forecast for that area. And those could include data that are available now, such as the amount of pollution in an area, the PM10 over time. Could include things like housing violations. Could include things like data like what we just saw, circulating viruses that can provide, that can exacerbate asthma in patients. It could include other things too, like the temperature in recent times that can be important for things like mold growth. It can be demographic factors like the deprivation index of an area or the access to healthcare. And we think that could be all boiled down to or combined into an aggregate level of risk for that particular area that may allow us to get ahead of the curve when it comes to asthma. Another use case that we think is very doable has to do with drug overdose. Just note here that none of these data are new. These are all available and in the public domain. There are data on the incidence of drug overdose at the national and state level, the drugs that are being abused, as well as demographic factors in drug overdoses. The same data are available, or the analogous data are available at the state and county level through the Ohio Department of Health. And here I've just taken, again, off the internet, examples of those data. And then Hamilton County Public Health produces more granular data, again, analogous to these. And having these data shown side by side allows you to understand what's going on in the local community and how that compares to the state and national level. And then finally, it's just one other possible use case. It has to do with suicide, where you could imagine being able to view data as it is sliced and diced by demographics that could include age, sex, and race. Again, total number of cases in a given time period, possibly broken down by local community, and stratified by things like incidents per year by race and gender, and so on and so forth. So to kind of summarize this, where we stand right now, we have several leads right now internal to Cincinnati Children's and the University of Cincinnati. The Fisher Health Center for Child Health Equity is planning to utilize SALT for dashboards and analyses that are relevant to child health in our community. The Cincinnati Children's Mental and Behavioral Health Institute is likewise planning to utilize SALT for dashboards for different programs that they have, and again for fee. SALT has been written in, or SALT support has been written into the University of Cincinnati recent Clinical and Translational Science Award recompete proposal to make it available to researchers doing community health research. And there's interest from other investigators and users as well. So our next steps include really developing SALT as a shared resource for complex community health issues, both inside and outside of the current users, and importantly, engaging non-hospital stakeholders in that effort. So with that, would like to take any questions that you may have. And again, thank you for your time and support of this.
Thank you to both of you for the presentation. It is always interesting to hear how the ARPA dollars were spent and how they're being utilized in the community. So it's very good to have the presentation. Appreciate that. And it strikes me that during, am I not working? Not working. Test. Oh, there we go. Oh, sorry. All right. Well, don't I feel like a superstar right now? I got my handheld mic. But during COVID, we were trying so desperately to understand the trends, try to get ahead of things, try to not only develop strategies to keep people safe and alive, really was what we were trying to accomplish, but also to communicate to communities where we knew there were increases of COVID-19 and we weren't necessarily messaging to those communities. I think about some of the new American communities, some of the African American communities, and so we had to, and Renee Mahaffey Harris is here, we had to switch it up a little bit and use some of our community partners like Closing the Health Gap to help us message out to save lives in particular communities where we were seeing those kinds of increases. So I really appreciate what was the practical application of collaboration, of collecting data, of trying to understand where the trends were, and using that to save people's lives in this community, because it really had a tremendous impact. So you talked a little bit about the sustainability of this and what you assume will be some of the uses moving forward. So thank you for that slide, because that was going to be a question that I had. But beyond that, when you talk about who would use this information, I mean, some of the users are obvious through the hospitals, public health, the health collaborative. But when you talk about non-hospital stakeholders, who are you talking about? Who might be interested in this data?
Thank you. Mentioned Renee. I think Renee would be a great.
Oh, that's why Renee's here. Well,
I didn't know you were back there. So nice to you. And our skilled nursing facilities, maybe emergency management agencies. When we think about the stakeholders we brought together during COVID, we had over 250 stakeholders that would come on the line from the housing community, from the food communities, from different service agency communities. We anticipate that in a time like a time very similar to COVID again, that we could get that platform out far and wide to those who could use that data to help inform their specific clients and their specific communities that they serve. And so, as David mentioned, that we need a fee service to support the platform. So when we need to mobilize for something such as a COVID-19 or influenza, the platform's available and ready to go, and the experts who know how to ingest the data into the platform and pull the data in and develop the visualizations are on staff and ready to serve.
Okay. Great, thank you. Commissioner Summer-Dumas?
Thank you. Thank you for all your hard work, everyone that was involved in this. I certainly appreciate it. This is a tool that we need to continue to use. We were in Hamilton County. I'm looking at Kesterman, Greg Kesterman, our health commissioner, and Hamilton County was just in the forefront of everyone, every county during COVID. And I know they would call Greg to find out innovative ways to deal with this, which is the first time, of course, for all of us. Just one quick question. I wrote a note about the first focus group, they wanted a legal framework to guide the data. And so was there a legal framework that existed, or who developed that legal framework?
So the Health Collaborative was at the forefront of pulling together the legal considerations and agreements with the hospitals during COVID to share out that health information exchange data, so we could share the positivity rates, share the utilization rates of how many people are in hospital beds or in the ICU with COVID during the pandemic. That took a lot of time, but we also had the grace of a emergency order, federal emergency order, that provided some leniency in the data sharing agreements at that time. Once those expired, we were back to the drawing board trying to figure out how we were going to share data. And at that time is actually when the opportunity for SALT came about as well. So we had to work through all of that. We have a lot of that in place now, but it took us about a year to get master service agreements and BAAs and all of those user agreements in place for the hospitals to say, yes, we will submit data to you, or yes, CliniSync can submit data to you, and we give permission to CliniSync to give you data, and these are the data that they can give you, and then we give permission for you to give it over to Children's. So as you can imagine, the hospitals are not really in the business of sharing their data with other hospitals. So submitting straight to Children's was really not an option. So it all needed to come to the collaborative, to a neutral body first, and then give permission to send it over to Children's to ingest into the platform.
Okay, great, thank you.
Sure.
And I heard you say about the SALT sustainability would be on a fee basis. Will there be any flexibility of any small community health organizations that may want to use this data, that their ability to do that, but maybe not be able to afford it?
So during an emergency, a public health type emergency, it would be available to anyone without fee. And so the fee is really to sustain the platform in between. And so I would turn that over to David to answer.
Yeah, I hear the question, and it's a difficult one. The intent would certainly be to make this available to anyone that can use it. We're in the process now of developing cost models to understand our costs and what it takes to apply SALT to a given project in terms of the degree of complexity and the degree of support that would be needed to utilize it for different customers. So it's a fancy way of saying we're working on it. We're determining what the costs need to be in order to move this, to preserve this platform moving forward. And we hear the concern and the need.
Thank you so much.
All right, very good. Well, thank you. Thank you to all of you for being here. Thank you also to Commissioner Kesterman out in the audience. We're looking forward to the practical implications of this moving forward. Hopefully it will not be in the middle of a pandemic, but it is good to know that we're ready. I mean, if Nick Crosley were here, he'd be loving this presentation, because this is our way of getting ready for something that might be coming, and not being overwhelmed and on our heels like we were during COVID. And I applaud all of you for your forethought and being on the leading edge of this, because it sounds like we'll be a model community for others to replicate if something else does come our way. So thank you so much for the work. Appreciate it.
Thank you.
All right, our next presentation is the organ and bone marrow donation presentation. Chase Mazajowski is here from UC Health, and I know there are a team of folks with you, so I'm going to have you introduce them, and we're looking forward to, I know you've reached out to all of our offices individually, and I think I don't want to speak for the others, I will say I'm generally supportive, I'm pretty excited about this, but really looking forward to the presentation.
Thank you, and good morning, commissioners. As President Driehaus said, my name is Chase Mazajowski. I'm with the team at UC Health. I have the quick pleasure of introducing the actual experts who will be able to come up here and talk to you about organ donation. The quick thing I would like to say is This work about approaching Hamilton County to consider a paid time off policy for organ donation came around last December. We had an internal UC Health call for all of our employees with Corey King, who you'll hear from shortly, the Network for Hope, and Renee Mojave Harris with Closing the Health Gap. And they all offered some of the stories about the work that we do in organ transplant. And we left that call saying, what are the action items that we can do to educate our community about the need for more folks to consider living organ donation? How can we do something that helps combat some of the myths and stigmas that may not be true about donating an organ, and how can we encourage more folks to consider giving that gift of life? And so when we reached out to the county worked very quickly and very thoughtfully on what could be a policy that would work with Network for Hope, UC Health, and Closing the Health Gap to accomplish that goal. And so you'll hear more about that in this presentation, but I will go ahead and introduce our first speakers. And so first from UC Health, you are going to hear from Corey King, who is our Executive Administrative Director for our transplant services, and Dr. Goval, who helps lead our transplant surgeries here at UC Health. So I will go ahead and turn it over to them, and I know we have a PowerPoint presentation to go through. Thank you.
Thank you, and welcome to you.
All right. Good morning. I'm Corey King, and I serve as the Executive Administrative Director at UC Health. And so I do thank you on behalf of UC Health and the many partners we have here today that we have in this work to express our appreciation for the Hamilton County for adopting the paid leave program that we have, for the employees for choosing the Donate Life gift that we have for becoming a living donor. So we have, let's see. Sorry, I'm pointing. Okay, there we go. So for the Donate Life living donor benefits that we have, we do think that this will inevitably lead to saving many lives here in Hamilton County. So we've prepared for you a quick look into the need for organ donation, and we have many partners here with us today that will be addressing the issue for these patients. And this would be the helping us save the lives would not be made possible without the work of many of these partners that we have with us today. And they will be talking on their behalf as well. And this would not be made possible without these many partners that we have that help us save lives. Sorry. Yeah, okay, sorry, yeah. So at UC Health, we're a nationally known transplant program here in Cincinnati. And for many years, 50 years, here in Cincinnati, we have one of the largest programs in the United States for living donation, as well as just transplantation in general. Our liver program is the 12th largest program in the United States here in Cincinnati. And our kidney program is ranked in the 15th percentile nationally for volume. So we are one of the largest programs here in the United States, here in Cincinnati. So living donation specifically helps us to save lives, and it's here in Cincinnati, being one of the largest programs, it does help us to have that. We have a program here that people do not need to leave Cincinnati in order to have this life-saving gift for organ transplantation. So here at UC Health too, we have been intentionally focused on supporting organ donation in the region and making the critical investments for our people, our facilities, and the policy to address the need for organ donation. I know that in 2022, UC Health helped support the House Bill 188 in Columbus, which was signed into law. And that was helped to prevent insurance providers from discriminating against living organ donors. So we gave proponent testimony up in Columbus and helped to support that bill, and it ended up being signed into law in 2022. Currently, we are working with the General Assembly for House Bill 122 to help provide income tax credit to employers, to private companies as well. So that's something that we're working on currently in Columbus. I know that through the county investment, we were able to open up a flex ICU in the fall, and I do appreciate that investment because it's really helped us to provide services to help more organ donation on the deceased donor side. And that Flex ICU has helped us open that donor care unit and in the partnership that we have with Network for Hope. And this has helped us to provide more organ donation, which inevitably turns into more transplantation here at UC Health. We were also one of the programs that helps give paid time off to organ donation to 10,000 employees at UC Health as well to become living donors. So we are asking the county to do the same, but we do that at UC Health. And so that is something that we offer to our own employees at UC Health. And finally, we continue to partner and support the organ donation space with the National Kidney Foundation, Closing the Health Gap, Network for Hope, Off the List, and those that advocate those who also give the gift of life. So this is something that we intentionally partner with some of ours that also help for this. So we do appreciate the support that we have from the Hamilton County. So I will turn it over to Dr. Govel, who will continue to talk about this as well. So thank you.
Good morning, and thanks for giving us a chance to talk about organ donation. A life of a potential recipient for transplant gets changed, or it's a gift of life that they can get from an organ donor. UC Health is proud to say that our transplant program offers the shortest wait times for transplant across the region, and we are able to get the patients off the wait list twice as fast compared to the national average for kidney and liver transplant. And our average wait time for a kidney transplant patient is 3 months compared to the national average being 10 months. Still, across the country, more than 100,000 people are waiting for a transplant or a life-saving organ, and almost 3/4 of those individuals never get a chance to get a kidney that subsequent year or a vital organ. So it's important that we raise awareness of living donation, because that gap can only be filled by more people who can step forward to donate an organ. And it is vital to encourage all backgrounds of people to become living donors. A more diverse donor registry increases the likelihood that everyone on that wait list will find a suitable donor match. There are a lot of genetic markers that are used to match a certain individual. So individuals with rare markers are more likely to find matches amongst those who share their racial or ethnic background. So living donation is a powerful way to give the gift of life while continuing to live a healthy, fulfilling life. Next slide. UC Health pretty much offers the only adult living donor program in the region, the other one being Christ Hospital, offering kidney transplant. When we look nationally, there continues to be a rising demand of patients awaiting life-saving transplants. As we can see on the charts out here, the number of transplants are going up, but they are not able to keep up with the demand, which is the number of patients who are being listed who need a kidney or a liver or a bone marrow transplant is going up as well. In 2024 alone, UC Health did 379 organs from 360 transplants, and that is, some of the patients do get 2 organs at a time, so that's why the number of organs are more than the number of transplants. There is an urgent need for living donors. Hamilton County stepping up to offer paid leave for living donor organs. And not only encourages more people to consider becoming living donors, but also provides the gift of life. But more importantly, it raises the awareness for the issue and encourages people to become registered organ donors. The biggest stigmata with the kidney disease is lack of awareness, and there are few stigmata associated with it. So publicly accepting the norm of and the gift of life, the living donors, we raise the awareness of kidney disease and how we can help these recipients. So those that take advantage of this benefit will quite literally be saving the lives of those in need of an organ. It also, as we discussed, the myths and stigmas of organ donation can sort of be circumvented when we make it a publicly acceptable decision. And on behalf of UC Health and our patients, we want to thank you for your leadership on this issue. And at this time, I'll invite Matt Niles, Executive Vice President and Chief Clinical Officer for Network of Hope, who can shed more light on need of organ, eye, and tissue donation.
Thank you, Dr. Govil. Thank you, everyone, for having us here today. My name is Matt Niles. I'm the Executive Vice President and Chief Clinical Officer at Network for Hope. Network for Hope is the federally designated nonprofit organ procurement organization that serves nearly 7 million people throughout Kentucky, Indiana, West Virginia, and the Cincinnati region of Ohio. Our legacy organization, CODA and Life Center, we have worked closely with local hospitals since the 1980s to facilitate the recovery of organ and tissue donation, which has saved and healed countless lives for our community. Next slide. Our mission is with our partners in our community. We honor, save, and heal lives by empowering people, enhancing capabilities, and expanding the impact of organ, eye, and tissue donation for our community. Our mission is why we are so grateful to support UC in conjunction with our longtime community partner, the Center for Closing the Health Gap, and Off the List by being here today. Next slide. So why does donation matter? Across the nation, there are over 105,000 people on the National Transplant Waiting List. Over 91,000 people across the nation are waiting for a kidney transplant. Within the Cincinnati region, there are 607 individuals waiting for a life-saving organ transplant, 475 of which are waiting for a life-saving kidney transplant. While Network for Hope facilitates the recovery from deceased donors, living donation matters because a number of people in the U.S. right here in Greater Cincinnati are waiting for a life-saving transplant, particularly for a kidney transplant. There's not enough deceased donors to make up the gap for those who are waiting. That is why we encourage living donation. If nobody gives, nobody gets. There's over 100,000 people on the wait list. A new person is added to the national wait list every 10 minutes, and on average, 20 people die off that wait list while waiting every single day. And those people that are waiting aren't waiting for a new medicine to come out to save their life. They're waiting for someone to say yes to donation. And that's what we try to encourage and do. So we thank you for your partnership on that. I'd like to introduce Darcy to speak from Off the List.
Good morning. Thank you, Matt. I'm so incredibly grateful for our partnership with Network for Hope and the others that are here today. So my name is Darcy Gibson, and I'm the founder and president of Off the List. Off the List is a local nonprofit that equips and empowers those individuals that are waiting on the kidney transplant list and their families with tools, the tools needed to find living donors. 9 years ago, my dad was one of those almost 100,000 people waiting for a kidney transplant. And although I was unable to be his donor, I took on the role as what we call a kidney donor champion, helping share his story and educating and raising awareness about living kidney donation. Because of our efforts, we know of 2 people who became living donors and 2 lives were saved. Living donation can significantly reduce wait times and improve long-term outcomes for recipients. Kidneys from living donors last an average of 15 to 20 or more years, almost double the 8 to 12 average for kidneys from deceased donors. However, despite the potential benefits of living donation, identifying a donor remains a significant barrier for those people that are waiting for kidney transplants. Off the List and our program called Together Toward Transplant was created to give those people that are waiting the tools, an individualized marketing campaign to effectively share their story and find donors. We use a personalized step-by-step program to give them all the tools they need to take action, share their story, identify donors, and get off the transplant list. What we find is that these people they're sick. They're in stage 5 kidney failure. They don't have the energy, they don't have the wherewithal to be able to get their story out there, and they often don't have the tools to do that. And so when we empower them and give them those tools, what we're finding is that more people are learning about living kidney donation and more people are taking that next step. Since our founding, we've created a meaningful impact. 56% of the families that go through our program are successfully finding living donors. That's more than double the national average of 23%. We're committed to providing individuals and the families of those people waiting the tools they need to find living donors. But I do strongly believe that the proposed legislation to provide the full-time pay for living donors within Hamilton County will reduce one of those barriers that we run into when we're sharing stories and people are asking about what's involved in being a living donor. And it will ultimately increase the number of people that will say, yes, let me learn more, let me see if I can help. So together, I believe that we can help more people get off the list and onto living. And I wanted to share just real quickly 2 things. One is that we're very excited that June 1st, in partnership with Network for Hope, there is a movie that is all about living kidney donation called Abundant that we are bringing to the Cincinnati area, again, to have people come and hear inspiring stories of hope and living donation to create those conversations and raise that awareness. And in closing, we can talk about statistics all day, but my day every day is on the front lines with these people that are waiting for kidneys. And so I just would like to share a little bit about somebody named Carmelita, who is on the screen right now. She lives in Cincinnati. Off the List has worked with her, and she was also in the 2024 Celebrate Life calendar that Network for Hope creates. And she shared her experience with dialysis is that 3 times a week for 4 to 5 hours, she hates it. She wouldn't wish dialysis on anyone. She's exhausted. She experiences forgetfulness, hair loss, blood clots, and passing out. A new kidney will allow her to pursue her dreams of getting married and having a family. A living kidney donor would give Carmelita a second chance at life. And on behalf of all the families, children, 20-something-year-olds, all the way up to 70-year-old something-olds that we work with, this is truly the gift of life for them for more time and a second chance to do the things that they enjoy doing. So thank you so much for allowing us to be a part of this and share some information.
Thank you all for being here. It's a really exciting program, and we're thrilled to be considering this here in Hamilton County. I actually have a friend who got a heart transplant a number of years ago, young man, and he's still alive. 3 kids, beautiful kids. He teaches over at Elder High School. He's the volleyball coach, all the things, giving back every single day because he is a person of faith and a person that follows his spirit and feels compelled to do that because someone gave him an opportunity to continue to live his life. So I clearly recognize the importance of this on both ends, both the recipient and for the donation. I've just got a couple of questions for you. So because I'm not that familiar with organ donation, I'm wondering what organs are available for living organ donations. You talked about kidneys. I saw bone marrow. Are those the 2?
And a lobe of the liver. So you can donate, be a living donor through your kidney, a lobe of your liver, and bone marrow.
Okay, very good. And Frank, is Frank in? I can't see you. There you are. I'm gonna ask you to come forward in just a second to talk a little bit about the policy. But as we do that, I'm wondering, as you go around and you spread this message of hope, really, through organ donation, what other employers have changed policies to allow their employees some time off in order to do this?
I want to introduce Renee. From the Center for Closing the Health Gap, and I think she might be able to shed some more light on that.
Okay. Thank you. Just want to know if we're out ahead, Renee, or...
Well, first of all, thank you. And my own personal testimony is a year ago, January, my brother got a heart transplant. But prior to that, I had already been strongly advocating for organ donation, and filling out that section of your driver's license to say you want to be an organ donor. Because of so many of the myths and mistrust that exist, particularly in marginalized populations, we needed to really have some more creative strategies to help people understand that everything possible will be done to save your life should you be at that place in your life. And that the myths, which I at one time believed, was that because I look like I look and the race I am, that perhaps my life wouldn't be saved. But what I changed that ignorance and that belief was understanding that to be a donor, they need you to be alive to actually retrieve your organs. And so that immediately changed my understanding. And so I've been advocating around the myths associated with organ donation and other mistrust. But when it comes to living donors, I know these statistics weren't shared and I may share them incorrectly, but when you think about over 100,000 people in the country being on the wait list for a kidney, and the fact that 50% of those individuals look like me or are marginalized in some way. So the work that we need to do to educate is even more important, to describe that we can live healthily with one kidney. And the gift of life that you can give to your family member. And I know Carmelita personally. And so when I think about her journey and that she has been advocating for some time to really help her family and others understand that I need a living donor. Yes, a deceased donor is one, but we already heard those statistics. But the myths and fears around living donation. And so anything that can be done through employers and governmental entities to make it easier for staff and workforce to understand that that is a gift that you can give and that your employer is going to be able to support the time that you'll need off for that recovery, but you can change a life. And so living donor advocacy is so critical because of the percentages of individuals who are marginalized, who don't yet have an understanding or gaining an understanding of organ donation is for all of us to be checking the box when we get our driver's license, but also understanding that we can save the lives of our family members because of the disproportionate number of kidney disease cases in this country that are representative of marginalized people. And so as it speaks to employers, I think that there are other governmental entities that are also exploring policies. And in addition to governmental entities, I think that when that leadership comes from our policymakers, I think it makes it very much easier for other employers to understand the importance and the ease at which you could create a policy that could support saving a life.
Well, we're happy to lead by example. So thank you. Commissioner Summer-Odumas.
Thank you so much. Thank you for all the presentations. Very informative. And I truly believe that everyone has a right to do, of course, what they want with their bodies, and anyone who makes that major sacrifice to give an organ, I have no problem supporting this policy. I think it's not only myths that people have in the community, but maybe it will be helpful education-wise as it relates to when you become a certain age. We can't use this organ. I mean, is there an age? I'm not asking now for the answer, but I think a lot of people think I'm too old to give my liver. Or so you were getting ready to say something, Doctor?
No, I was just going to answer your question.
Yeah. Oh, okay. I didn't know if I would get one, but I certainly support the policies. Yes, sir.
Again, to the age, there is, again, we want them to be adult age more than 18, preferably over 21, where they can think through. As far as the older cutoff age, there is no absolute stated age. It's on the health of an individual. And for kidney transplant or kidney donation, we have used people who have, we have taken kidneys from people who have been age 75 as well. And so it all depends. Like many a time, spouses would donate, so it's circumstantial, but their safety and their health is the primary concern. So rest assured, every living donor goes through a very rigorous workup. Something I always tell them, that just because if I raise my hand to be an astronaut doesn't mean that I become one, which means I go through a battery of tests and everything. And so when we look within our own data, almost out of every 10 people who step forward to be a potential kidney donor, maybe one makes it to the other end. But that definitely is a very strong support that we make sure that it's a very healthy donation process. And
So those who maybe are listening and didn't hear it all completely, but you can be a healthy 85-year-old depending on your ability. Okay.
Thank you. Thank you very much. Appreciate that information. We're all able. I think everybody in this room now knows that they're able to do this. So very quickly, Frank, I wanted to ask you to come forward. Frank Spataro, head of HR. So we've got the policy in front of us by way of a resolution, and I think we're going to prepare to pass this on Thursday at our legislative meeting. But I did want to highlight, just so we're all familiar with what we're talking about here. So I see under the eligibility and compensation and benefits, the kidney or partial liver donation up to 240 hours of paid leave in a calendar year beginning the date of the procedure, and the bone marrow donation up to 56 hours of paid leave in the calendar year beginning the date of the procedure. So are we to understand that we will follow, or our policy is reflective of what's in front of us?
That's correct.
Okay. So beyond that, then I think that speaks to what people could anticipate. Have we done, obviously we don't know how many people might want to participate in this program. Have you done any kind of fiscal analysis on this?
No, we haven't looked at speculative or projected information. I mean, that's one of the tasks that we have, assuming passage on Thursday, is to publicize this new policy and make sure that everybody is aware of it, and those who want to take advantage of it can do so.
Okay.
Yep. I did want to add
Yes.
one thing, though, to the 240 hours for transplant and the 56 hours for bone marrow. That does not subtract from an individual's annual FMLA allotment of time, nor does it detract from their paid sick leave balance.
Very good. Thank you. That's really important information. Thank you, Frank. Really appreciate it. Okay, so we, as I said, will have this listed on our agenda on Thursday at our legislative meeting. I feel like you've at least got the majority sitting here in favor of the policy. So thank you so much, all of you, for working on this, for bringing it forward. We're really thrilled to be participating in this. And once we pass it, if you want to utilize us as an example, please do that, because we are thrilled to be an example on some of these things in leading other organizations in the same way. So thank you again for your work and for bringing it to our attention.
Thank you.
Okay, thank you. All right, the other two items we have are executive sessions. So I am going to move that we go into executive session pursuant to ORC Section 121.22G2 to discuss the sale or acquisition of property, and a second executive session pursuant to ORC Section 121.22G2 to discuss the sale or lease of property.
Commissioner Driehaus,
Yes,
Commissioner Summer Dumas.
thank you.